Thank you for coming to CTeL's Digital Health Summit. My name is Jake Harper. I'm a partner with Morgan Lewis in Washington, D.C., as well as a CTeL board member. And this morning I have the distinct honor and pleasure to introduce Senator Cindy Hyde-Smith from Mississippi. She's going to be leading some of our opening remarks this morning. And the senator is a tremendous advocate for telehealth and digital health technologies, and she's been a fierce supporter of it ever since her time in Congress. She started in 2018, and since that time has really focused not just for her constituents in Mississippi, but for all Americans to really embrace the value that telehealth can really bring. So particularly during the COVID-19 pandemic, where we had this tremendous shift from sort of a very localized, in-person world, and really tried to emphasize the value and accessibility of telehealth for all people. Senator Hyde-Smith was one of the leading proponents of that, being an original co-sponsor on the Connect for Care Act, as well as just leading the charge in a variety of places. She's also been a frequent speaker and friend to CTeL, and so we're really excited to have her again to open our summit this year as well. So with that, Senator Hyde-Smith, thanks so much.
Thank you so much for that kind introduction, and it is really good to be back with you. When I look at this group, I think of how far we've come and the changes that we've seen just in the last few years that made such a difference in so many lives. But I come from rural Mississippi, and I know how important it is to have the telehealth in those rural areas. But all of you just bring a different perspective to the discussion, and we're facing so many things in healthcare. One of the things I'm tremendously concerned about is healthcare, and especially healthcare in rural areas, and the way that we implement the amazing things that we can do, but you have to have that connection. You have to be with them. And I have spoken at this event many times, and it is just great to be back. But I can speak from a resident of Mississippi. I tell them all that time that the name on that door says Mississippi, and I've got to represent those people that I'm so proud of, that I'm so delighted that I get to represent. But I know where they are, and I know how we live. My mother is 86 years old, and there's several times that we have gone down to her local emergency room just because of low blood oxygen or different things. And I'm thinking, what about we had to drive an hour to do this? And that could be a reality so very fast, and I know that. But as a member of the bipartisan Senate Telehealth Working Group, it's been exciting to work with like-minded colleagues that get it also, that to craft legislation and to be able to advocate greater for telehealth. But we have advocated for telehealth since and well before COVID-19 pandemic. Before COVID, many years ago, I was in the state legislature, and I can remember the first time that I walked into the University Medical Center, and they had all these TV screens in there, and they were newly installed, and they were talking to all these rural healthcare providers throughout the state. And I'm like, thank you, Jesus, that this is here. But I can remember how different it was, and trying to explain to people exactly what was going on and the importance, and especially the importance of the appropriations for things like that. And that is something that we literally cannot live without, and now we've become very dependent on it, but it's been in a good way that it's been so beneficial. But I've had to fight for funding, for money, and that's my job. I don't know how to check your blood oxygen level other than that little clip, and I don't know how to do the things that you do, but I know what my job is, and that is to make sure that we have the funds to continue to do this. And it was pretty difficult before COVID, but I'll be honest with you, after COVID, it's not as difficult because the world realizes it now. And it just, for the affordability of it, the high quality of it, you can't beat this. And it's a shame that, it took a pandemic to highlight all the advantages. But I am happy America has been able to see just how vital telehealth is to our healthcare system. But even with the rapid reliance on telehealth during the pandemic, we still need to ensure emergency relief measures removes hurdles and allow greater growth in telehealth. But I used my position on the Senate Appropriations Committee. That kind of sounds bad that I used my position. But, buddy, I did. I came down like a heavy hammer to have the Telehealth Services During Certain Emergency Periods Act of 2020 added to the emergency funding package. And this allowed the Secretary of Health and Human Services to waive the requirements, just certain requirements, during the public health emergency to ensure Medicare beneficiaries could receive the care they needed at home without a necessary potential exposure to, obviously, the virus, the diseases, and things. But it was a huge win for telehealth and medical community as we entered into the pandemic that we had that in place. And on May the 11th, 2023, the COVID public health emergency ended, but Congress extended the telehealth flexibilities we fought to achieve until December of 2024. So we'll probably have to go back to the mat again, but that's okay. But while the extension is a win, we've got to work together to make sure that we can make those permanent. And the reason we're a little late is I was waiting on the binder. We do this all day to so many groups, and I thought, I have to make sure that I have the correct information, the dates, and the acts. So y'all got to bring me the binder, so I apologize for making you a little late. But we reintroduced that. We're trying to get it on a permanent basis so we can obviously support you and the beneficiaries utilizing telehealth and enhance the telehealth oversight and gather more data on the impacts of using this. It seems simple. It seems like a no-brainer that this is so easy to explain, that, this is what we're doing, the telehealth, and this is the reason we're doing it, the rural areas. And I've done it so many times I can do it in my sleep. But still, you meet with groups who make decisions that may want to use that money for something else. And so you have to, you have to keep refreshing memories of exactly why it's so important. But I do hope the Connect for Health Act will come to a vote in the Senate and be one step closer to coming law. We all know this game. It's a chess game. We have kickoff at the beginning of the first quarter. We go through the session. Sometimes we have to punt, and sometimes we have to tackle and just take out who we need to take out. But I think that we will get there. I'm little, but I'm mean. I've always said you better make them love you or better make them scared of you. One or the other to get things done. But I just want you to know that I'm still your advocate, and I will always be your advocate because I know what's out there, and I know how critical that it can be in so many circumstances because you don't need it till you need it. And when you do, you want everything to work, and it's your family member or it's either you that's there, that you want to make sure we have all the technology, we have the means to continue to pay for the technology because it's not cheap. It is expensive, but it's money well spent. And I just want to thank you for doing what you do. I mean, there are no words to tell you the gratitude that this entire country should have for you. Because those in healthcare, you never know what the next step, the next moment's going to be. We sit here on the Senate floor and we go to lunch and we go through the policy and we get things done. And we don't live your life. So it's easy when you don't see it every day that the importance lowers. But you see it every day and you do it every day. But you're doing the work of the Lord, I'm telling you. You are doing the things that matter in lives, that truly matter in lives. But we did have an incident last week, and I guess I can tell this publicly, that I thought, where's my healthcare folks? I came into lunch Thursday. Every Thursday, a different senator provides lunch from their state, and we call it the members' lunch, and I bring catfish from Mississippi and beef and all this stuff. Well, last Thursday, it was Iowa's turn. So Senator Joni Ernst brought all these wonderful pork chops from Iowa. They raise a little bit of pork in Iowa. They raise a little bit of corn in Iowa. So we have these great corn dishes. But Joni Ernst got choked on her pork chop. And Rand Paul was standing there. And I came in like when she was still kind of laid out, but it had already happened. Rand Paul came in and looked at her and said, "Are you okay?" And she's doing this. So he helped her 3 different times. And finally, on the 3rd time, he got it up. And Joni looked at me and said, "Rand Paul just saved my life." And I thought, well, I won't pinch his head off with times that I want to pinch his head off. I may let him breathe a little longer. But, and he had to do the same thing with another senator that was a lot bigger, Eric Schmidt. He had to do the same thing on Eric not long ago. And he said it sure was a lot easier on Joni than it was Eric, because Eric's a big old, great, tall guy. And but he was there to do that, and I really say it in teasing when I want to pinch his head off, mainly in teasing. But we sure was glad he was there and that turned out the way it did. And I thought, you know, we think we're so far removed and we don't worry about this stuff until you look at somebody who is truly having an episode that, thank goodness, Rand was there to help her with. And so I've already told my chief, I want that training for our office, you know, and I think everybody else did too. They said, well, you know, the Capitol will do that training for you. But it's just that day-to-day stuff that you deal with that so many times we take for granted, and I apologize for that. I apologize that we take what you do for granted because it comes back very, very fast. But we have a lot of challenges in this building. You all have a TV. You know what's going on. And you just have to get up every day and realize, you know, we're going to wrestle this bear again today, but I've had some sleep, I've had something to eat last night, and I'm ready to wrestle that bear today. So I just ask you to remember us as the ones wrestling the bear, but we're wrestling it on your behalf. And I just thank you for what you do, but I thank you for letting me be a part of you. I appreciate you.
Well, we thank the senator. She always provides such wonderful remarks, and so we're lucky to have her. The format of this summit is going to, can you guys hear me okay? The format of this summit is going to be more roundtable in nature. So what we're going to do is if you guys could all open your agenda booklets, you will see tabletop discussions for I believe almost all of the panel discussions. So what we'd like you to do is take a look at those pre-drafted questions, think about them, and the tabletop discussion, what we're going to do is we're going to have the presenters provide some substantive information, and then we're going to break for about 5 to 7 minutes and discuss the tabletop discussions. For some sessions, we're going to actually whiteboard it with sticky notes, and we'll provide you, each table will have a different color sticky note, and we'll put it up on the board. And the idea of this is that this meeting is going to be very interactive. So let's get started. We have with us today, first panel of the CTeL Summit, Preparing for Uncertainty, Charting the Path Forward Post-PHE Waivers. And we are very lucky to have with us Dr. Fernando Porter, Jeremy Schreier, and Bartley Bright with Privia. The tabletop question is, how might the expiration of PHE waivers impact telehealth services and access? So that's the question that we're going to be talking about. Number 2 is, what are the key considerations and best practices for ensuring continued success in telehealth delivery while complying with anticipated post-PHE regulatory requirements and policies? And finally, what are your fraud and abuse concerns in an uncertain legal and regulatory environment? So why don't we get started now with our first speaker, and I believe that's Jeremy, is that right?
Yeah. Thanks, everybody. I'm Jeremy Scherer. It's great to be here. Thanks for being here bright and early this morning. I'm really tasked with trying to help sort of set the table and then get out of the way so we can hear from the other 2 speakers up here. So I'll try and do that quickly and succinctly. I think it's important to think about, we're sort of, already this morning we've been talking about this impending cliff. We've been talking about this telehealth cliff. What is going to happen when these waivers go away? And I think before continuing that conversation, we should talk about and sort of remind ourselves, what are these waivers? What do they do, and where do they come from? Telehealth has come a long way in recent years, thanks in large part to the COVID-19 pandemic and certain waivers that were put in place, which made it so that on a temporary basis, a series of statutory requirements set forth in the Social Security Act, which normally govern telehealth services, were either waived or drastically expanded. They were, each of these sort of 5 statutory requirements were fundamentally changed in one way or another. And so what does that do for us as folks who are providing care, as folks with organizations providing care, or as patients? It completely changed the landscape that we've known since the late 90s. You saw drastically more services that are can be provided via telehealth and covered by the Medicare program. We've seen new types of practitioners who can provide care and bill for that care when it is furnished via telehealth. We've seen on the originating site issue, under normal circumstances for a long time, the struggle that we had was that unless folks were located in certain types of brick and mortar facilities or in rural areas, they were not able to receive care that was provided via telehealth. That changed. We've seen modality restrictions loosened. We've seen audio-only care reimbursed, which was not done historically. And so it was a complete paradigm shift. And where we find ourselves now is, unfortunately, years into this pandemic, we've developed clinical workflows. Folks are accessing care, utilizing telehealth in a way that they've not done so. And if that all goes away, there are going to be real implications for our healthcare system, for patients, and for providers. So I think just sort of remembering where we are coming from on that, and that should those waivers go away at the end of 2024, there are going to be serious ramifications. And so for all of us here to talk about that, to think about that, and to really continue advocating and pushing for those changes to largely be made permanent. So with that, just setting the table, I'll pass this off now to Bartley. Are you next?
Yep. So since I can't see people in the back, maybe I'll stand. So my name is Bartley Britt. I'm the Chief Medical Officer of this company named PHE. And PHE is a medical group business, but we're a medical group with over 4,000 physicians, 1,000 locations. And so Jeremy was talking about, well, COVID happened and all of a sudden there was more access and there was emergency legislation. That didn't just happen. It required a lot of investment, a lot of planning, and a lot of very, very quick action. And so the simple question on this is, what happens if they end? Well, healthcare changes. And so depending upon the practice, you know, we get a lot of patients who get healthcare from us remotely, because that's the way they get access. And what virtual care provides is access to care. And so if the legislation changes, a lot of things that are good, as the senator described, go away. 2, we need to plan ahead. And so we were fortunate in that when and I wasn't around at the time, Fernando actually runs our virtual care, and we'll talk much more about it, so I'm sort of starting at a higher level. Fernando will then come in a little bit more at the street level. We were fortunate to have thought about this ahead of time, but it takes investment, and technology takes time to implement, as many of you in this room know. And so we were fortunate to have a baseline that we were able to then quickly provide access to patients when the world, as we all experienced, really kind of closed over the course of a week or 2. And so if what we're asking for as a physician group providing care is for a decision on this legislation to be made permanent, or at least long-term, but to be made soon or early in the year 2024, because we need time to plan. Patients need time to plan. Even if the patient says, oh, I was feeling fine yesterday, I'm feeling sick now, I want care now, we have to have thought about how we're going to provide that care 6 months ago and set stuff up, from technology to physical technology, a phone, a video, to actual staffing, because generally healthcare so far is still a healthcare provider point of or a delivery mechanism. So it would be tremendously disruptive to the healthcare we provide in 14 states if all of a sudden this is turned off, and if we don't get adequate notice that that's happening, which I think is a bad thing for access, which is important for this thing, which we can perhaps talk about, the quadruple aim of cost, quality, patient, and provider satisfaction. Access supports cost. Access helps us control quality. Access most definitely is a patient satisfier, and it also provides satisfaction to these people we call clinicians, physicians, practitioners who are so essential to the healthcare system. So with that, I'll pass it off to Fernando, who runs our virtual care and can maybe talk a little bit about that and his point of view on this. Thanks.
So my name is Fernando Porter. I'm a primary care physician here in Washington, D.C. and Maryland. And I've been in private practice now for 3 years, and I sort of got into this role of with PHE running the virtual clinic, or virtual health in general, which is something that's separate and aside from my primary care practice, because of the background that I had working with a telehealth company from its startup phase. And so what I learned is that early on, telemedicine was, from a primary care standpoint, was a have and have not game. It wasn't covered very much by insurance, but it was either a fringe benefit because your company, whoever, decided to say that we want to have access to this cutting edge technology. The other piece of it was I'm running check to check. I don't have a lot of money to spend on healthcare, and when I do a Google search, there's somebody that I can see for $35 or $50. And I can get care. And the vast majority of those patients were in rural settings or very, very urban settings where they just didn't want to go to the emergency room, foresight on their end, but they just didn't have it to go spend a bunch of money on healthcare, and they didn't have a healthcare plan. So now fast forward to the pandemic. Now everybody has been able to, by force, so to speak, experience what telemedicine has to offer, and I don't think it's a secret now that it has given us a tremendous amount of access, and also been able to give us the ability to provide a different level of care, whether it be remote patient monitoring or just, I have one of my favorite patients is a 89-year-old she gave me permission to talk about her today, but she's an 89-year-old female, and she knows how to use that iPhone. And if there's ever a problem, she will pick that thing up, text me and say, "Hey, doc, I need a visit," right? And so it has given her tremendous access to not necessarily have to call her daughters or her sons to say, "Hey, I need to go to the doctor." She has direct access to me to be able to do that. And so I'll take it from two lenses. From a private practice standpoint, if this goes away, this is a significant portion of how I run my practice, right? I am on the high end of utilization. I use it probably somewhere between 20 to 30% of my patients' visits are telehealth. A large part of that is because my staff drives an hour to an hour and a half a day to and from home. So part of it is just trying to be a good boss and say, "Hey, don't worry about coming into the office today, or make sure you take the calls from home, or I only need one of you in the office today, to help me." And that allows me to be able to see my patients virtually in that regard. The other piece of it, obviously, is the access that patients get who have like disabilities and things of that nature. And so cutting that out means that I now have to, one, lessen the access that my patients have to me directly. And then two, it will basically lessen I have to take a hit, essentially. I have to figure out how to refill my schedule because I've constructed my schedule in such a way. And then the third thing is that my overhead doesn't change. So there's a piece about this, this expiring that I don't think a lot of folks are talking about, which is actually the visit cost or the visit reimbursement being the same as it was if I were in person. Well, the argument that, "Oh, well, you needed less to do it." No, I didn't. My staff salaries are still the same. My electricity is still the same. Verizon doesn't charge me less because I decided to do a virtual visit. My rent doesn't become less, or any of that kind of stuff. So, I think those are the things to think about when we're saying that we want to change what these parameters look like as far as practice in the outpatient setting. On a national scale, as Bartley was speaking of, I have had the privilege of leading this small team to take care of people across the PHE footprint, which is about 14 states. And the one that really comes to mind to illustrate the point is in Montana. When we went live in Montana, telemedicine was still a thing that was big and scary. And within our previous scope, we have to practice we have to play this value-based healthcare game, which means we actually have to deliver on quality. We actually have to deliver on making sure that the patient is healthy. So it's not necessarily a game of how many patients can I see, it's how well can I take care of this patient? How healthy can I keep this patient? And so we were tasked with, the virtual health team was tasked with, there's an exam, a particular exam called an annual wellness visit. And we were tasked with scheduling visits to try to close this value gap that we have, this quality gap that we have, that we are responsible for with all our Medicare patients and all our Medicare Advantage patients. And so what you find is that there are even providers that are not necessarily well versed in it, but a health system can come in and actually provide the care that is needed for someone who might have to drive 45. So what the senator was speaking about actually resonates pretty well with me in that scenario of being able to take care of patients who, even when they want to go to their primary care doctor, it's 45 minutes, an hour drive, so which means they have an hour and a half to 2 hours on a no traffic day. You know, and that's something that's significant, and I think that's. I think those are illustrations, the business side of it, the rural side of it, the access side of it. These are all things that we need to think about when someone is saying, okay, we need to change what this PHE, the fabric of it looks like. And then also, let's just keep it going, because it's working.
Okay, I'm on the clock, 1 minute. Carol Yarbrough, representing Table Crane Our Necks, backwards. We've decided that to overcome the extinguishing of the PHE waivers that have been extended through 2024, we really have to concentrate on payment parity to make sure that we all receive the non-facility rate when the new CPT codes come out in 2025 for telehealth visits. There's a lot of talk earlier too about, well, it does cost the same. It's always cost the same. Why should we all go back to the facility rate for reimbursement for pro fees? And then, in California, at least we get 27 cents a minute for transmission time. That's a Medicaid code. So really payment parity, in addition to the 27 bills that Jasmine counted up recently, would really help keep things moving forward.
So we have payment parity for this table. And I think just to be clear though, so payment parity is usually like a state-based issue. So you mean reimbursement for telehealth?
Yeah.
Okay.
Yeah, payment parity, yes.
Okay.
Facility versus non-facility rates, which is
Right.
a slightly separate issue.
Yeah. Yes. Okay.
Talking in tongues again.
All right. Who, Fernando, you want to be the...
All right. Aside from the payment parity piece, I think another piece of it is, and I think that's the primary thing for most patient care providers. Another piece of it is business development. I think when I think about even behavioral health, there is a obvious need for behavioral health across the entire country, but I think we stunt ourselves a great deal because I think they're out of fear. If I can't tell beyond 2024 that I can practice without certain restrictions that currently exist, particularly the in-person restrictions that exist, I am not likely to want to say I want to develop a multi-state behavioral health company with psychiatrists and psychologists and clinical social workers, et cetera. I'm not likely to want to do that because that's an investment that I don't know will go beyond 2024. And so, currently we're able to do that, but that expiration really will put a dent in that type of investment, and even the ones who currently are trying to do that, they're going to have some things to really, really think about as this year progresses if they haven't began to do that already.
So we hear payment parity from this table. This table is concerned about the uncertainty that is going to impact the long-term development of mental and behavioral health programs, and then also just the expansion of telehealth. All right, who would like to speak from this table? Okay. If you could announce yourself and stand and look towards the camera.
Absolutely. Tamara Perry, Children's Medical Center, Dallas. So for our table, we really discussed what are the key considerations and best practices for ensuring continued success in telehealth delivery while complying with anticipated post-PHE regulatory requirements and policies. So for us, it's very difficult. I'm with the pediatric hospital, and within that space, there are a lot of regulations that have to be in place. What we've done to really provide for, I think, a roadmap post-PHE, just in case, is bringing all of the stakeholders to the table. So the physician teams, the regulatory teams, compliance, legal, all of the above, and our IS and operational teams to ask, how can we make this work? So during PHE, we were able to set up quite a few programs inside the walls of our hospitals, allowing for tablets and video ability at every bedside. When we started these programs, we're very transparent. These may not be able to stay in place post-PHE. We're not able to bill inside the walls of our hospital for specialists that enter in after PHE possibly, but how can we make this work? And I think that's the key for us. What is, and our organization asks for the ROI, we have to transform that into what is our return on value, our value add for virtual care, virtual health, virtual medicine, and putting those physicians and stakeholders up front to say, we have 1,000 patients that will not receive care if we do not provide these, and how can we institute waivers? And working with our compliance teams, I think they've opened their eyes to no is not the only answer every time. But and we have to then provide for them what are the options, because it's not something they'll figure out alone, but we can work together, say, here are options post-PHE. So we've worked with our regulatory teams, and we have a team in place post-PHE, workforce. What do we need to do if it happens during that time?
Good morning, everyone. Is this thing on? Oh, yes, it is. Good morning. I'm Tom. First off, I want to thank our panelists who were extraordinarily articulate in framing the situation as we have it. Nobody in this room is arguing with them, clearly. And the discussion we had at our table was this. I'm not necessarily sure that the proper form of the question is claw back to pre-pandemic, prehistoric times, or full steam ahead. There has to be a middle ground, because not everybody outside this room agrees with us. And so when I look at how we structure a solution moving forward, I think it's important that we don't fall into the trap of an either-or situation. And as my much more articulate colleague had pointed out, there are a number of things that we can point out to that we may be able to do, like I'm all for payment parity. Audio only, that would be something that I would be able to give up on if we were to get something in return. And again, the dance begins. So that's what I got. Do you have anything to say?
I think that was perfect, Doctor.
So I'm Linda Brannigan. I'm the director of telehealth at UCSF. And if we lose the PHE waivers, I have to retire. The operational impact is difficult for me to fathom. I just did a little quick math. We do between 600 and 1,000 video visits with Medicare patients every single clinic day. So the operational impact of just rescheduling all of that, and not to mention the fact that we've reconfigured clinics, we don't have enough parking, our staff has made choices about where to live because they have, opportunities to live farther away from very expensive San Francisco. I can't imagine it. So, but one thing that we would have to do is really double down on the advocacy, right? Because it can't stay that way, right? It's not just my patients, right? It's all over the country. So we would have to just absolutely double down on advocacy, get the undoing redone or whatever, and make sure that we do get the changes that we need and we get them in a way that's more permanent than kicking the can down the road every 12 months.
Dr. Brannigan, one question.
Yes.
What will be your sort of cutoff date where you have to make a decision, right? Like if we don't get something from the Senate by October 31st, 2024, are you already saying we're done?
See, I might retire before then. I don't know. We would need a good 90 days. I think we do book appointments a year out in some clinics. We would need a good 90 days. And then we would have to cherry pick the Medicare patients because we have great parity laws in California. So I'm not worried about private payers and I'm not worried about the Medicaid program. So it'd be cherry picking the Medicare patients and figuring out how they're all going to start driving in. Yeah. Great question. Thank you.
Morning, everyone. I'm Joe McMenamin, and I'm a lawyer with Christian & Barton. I do digital health. I think our table basically is hoping that the powers that be will kick the can down the road because we're pessimistic that next year, even if it were not an election year, we are not going to get definitive solutions to all the problems we're facing. So we're hoping that just as they've done innumerable times before, Congress, DEA, and all the others will basically keep things as they are for some brief period of time that will give us a little more breathing room until the next crisis comes along. We did not get terribly far at all on the fraud and abuse issue, but with respect to how to cope with all of this, apart from ideas that have already been well articulated by others, we think that an important aspect of this may well be trying to educate the American public about the cliff that we're facing at the end of 24. Our guess is that the great majority of U.S. citizens and Americans generally have no idea that on December 31st, 2024, we're going to have a sea change with respect to this form of care. And if more people knew more about it than they do, maybe there might be some marginally greater chance that we will see some actual definitive solution to these problems. Did I miss anything?
No.
Thank you. Thank you.
Morning, I'm Bethel Korn, Program Director with Virtual Services with BJC Healthcare in St. Louis, Missouri. And I think first and foremost, our approach has just been kind of talking to others is, can we just make these permanent so we can start planning everything else? And we've shown, I think everybody has shown the success of virtual through the pandemic, and we'd just like to continue pushing for them to make those permanent. I think, again, we agree with what everybody is saying here, and I just lost my... We would need to know by... Thank you, sorry. And I think it was Jacob said, make the comment, like, we would need to know, like, by June 1st so we could start to unwind. I mean, we'd spend more time trying to unwind than we did in the setup. And most times it's not the case. I mean, to try and undo all of those patients would just be such a heavy burden. And I think, again, even staffing losses, just the gaps that it would cause would just be tremendous. So I think we're trying to remain positive and steadfast and pushing for them to go permanent and trying to keep pushing for healthcare outside of even those areas.
Hi, everyone. Jeremy Scherer. I lead the digital health practice at Hooper Lundy and Bookman, which I didn't mention before and probably should have. As you'd expect in a group of like-minded people, a lot of what we discussed has already been covered. So we sort of wandered in a slightly interesting direction, I think, and I'm going to pick up on what Joe was talking about in terms of education. But rather than talking about it at sort of the public at large, I think we were focused more on what is it that is going on in this bubble that we find ourselves in on Capitol Hill, where we're finding that there are there's any sort of opposition or questions around telehealth. I mean, you often hear folks say telehealth is more popular than puppies. Why is this a contentious issue, right? And so what we come back to is it's not that folks are thinking that telehealth is necessarily bad, but there are concerns that increased access to care that's provided via telehealth will lead to a massive influx in utilization and therefore drive cost, and that care that's provided virtually is somehow more susceptible to fraud and abuse. Now, and that sort of ties into the third question, and by and large, from what we're seeing in terms of what the data is showing, folks are are sure they may be able to access care. We're not seeing a huge uptick in terms of volume that would lead to some sort of ballooning costs to the program overall. And folks, a physician like Fernando does not become a bad actor when given access to synchronous audio video technology or any of the other tools that we're talking about, right? But in terms of just sort of from an education perspective, from a messaging perspective, keeping those ideas sort of front of mind as we have conversations here, I think is really important, and is sort of when you think about what are the narratives that we need to bring forward in order to get where we need to go, whether it's in October or it's in November, hopefully sometime before the end of December 2024. These are things that are just important to keep front of mind. So that's where we landed.
All right, so do we have any questions from the audience? We have about 6 more minutes before our next panel. All right, if we don't, why don't we just take a 6-minute transition break? And if our panelists for the next panel could join us up at the front.